Gus Alva. I'm currently the medical director of ATP Clinical Research, a private neuropsychiatric clinical research group that houses a center of excellence in the city of Orange in California. Super happy to be here. And in regards to the agitated psychotic patient with Alzheimer's disease, it's important to recognize we're talking about one condition, but then three different clinical entities. The one very important one is cognition, right? And obviously Dr. Ritter is going to be addressing that particular point. Very well versed to speak about it, including new treatment modalities like monoclonal antibodies. It's important to recognize that we now see Alzheimer's disease as a condition which there's a continuum in which mild cognitive impairment begins before the onset of mild and then moderate and then severe Alzheimer's disease. Across any stage, we might be seeing different things like agitation or psychosis, which might herald a worse outcome in that patient. And that's where it's so important for a clinician to be able to identify that and do something about it. But in addition to that, it's important to understand what has been studied and what has been proven to be beneficial. And in the case of agitation, we have two FDA-approved medicines, right? One being an atypical antipsychotic, the other one being an agent that's utilized to treat depression that works relatively quickly and has a lasting benefit. So it's not a bad idea to afford patients the opportunity to at least be able to be aware of what's there for them. In the case of psychosis, we obviously see black box warnings associated with the use of all antipsychotics, particularly the atypical antipsychotic class carries a big black box warning that says, if you happen to have dementia and you've got psychotic symptoms, you're treated with one of these medicines, your likelihood of dying goes up, right? Because of cardiovascular or lower respiratory infectious issues. So it's not a bad idea to take a look at that and see what work's been done. So one of the things that I'll be speaking about also when addressing that is work that we've done with, say, a 5-HT2C, 5-HT2A partial agonist. Well, inverse agonist, I should say, right? So that means it's a super antagonist, right? And it's the only medicine that's currently FDA approved to treat Parkinson's disease psychosis. So when we did the trials like the Harmony studies, we basically saw a diminution of psychotic symptomatology in individuals in a safe manner. But the FDA just felt like the data was influenced a bit more by patients with Parkinson's disease since we had actually brought in different dementias into the sphere of that particular trial. But it's not a bad idea to then be able to sift through information that has been collected. Granted, there's no FDA-approved treatment, but it's not a bad idea to at least offer individuals information about work that's already been done. So even the concepts of treatment-resistant depression or difficult to treat depression are very important. If we talk about treatment-resistant depression, we're almost introducing, again, sort of like the resistant patient, right? And to a degree, it's a connotation that's negative in nature, right? My patients aren't resistant to getting better. They want to get better, right? And maybe aligning difficult to treat depression is a very important thing because it really isn't just looking at how many failed attempts there have been at remedying the problem. It really is ascribed a little bit more towards quality of life and functionality.